Dr. Savage presented yesterday on the telomere biology disorders, and she outlined how, abnormally short telomeres are really almost a universal feature of these conditions. And the consequence of these very short telomeres, right, is chromosomes get destabilized, this impairs the ability of cells to divide, this can lead to cell death, and this can lead to a range of medical problems. And when we think about the bone marrow, this is an incredible organ. It has to, starting with these stem cells, give rise to a whole host of different types of cells that circulate in our blood. And what's really incredible as well is not only the ability to go from this multipotent stem cell that can lead to all these different kinds of cells, but it has to do it at phenomenal rates, right? So it's estimated that hundreds of billions of cells are made from the bone marrow nearly every day in grown, 70-kilogram males. But the point is, a lot of blood cells need to be made. So you can imagine the stress on this organ when you've got very short telomeres. It's leading to chromosomal instability, or leading to these signals that tell that stem cell or the progenitors to stop dividing. They don't have enough telomere length for the telomeres to do their jobs. So this is one of the reasons why we believe that bone marrow failure is really common in dyskeratosis congenita and the other telomere biology disorders. So what do we mean by failure? That's when the bone marrow is unable to make a sufficient number of blood cells. There could be different reasons the bone marrow fails to make blood cells. If your bone marrow is chock full of leukemia, for example, you would be very anemic, and you could be very thrombocytopenic, have very low platelet counts, right? What we see in the context of the telomere disorders is bone marrow failure when the bone marrow that normally, so this is what a biopsy looks like. Maybe some of you have seen what a biopsy looks like, but maybe you haven't. But this would be that little sliver of bone marrow sliced and put on a slide and stained in a special way. So this is what the pathologist is looking at. And this dark part, this is the cartilage, it's not the bone marrow cells, but rather, it's not cartilage, but it's the blood, the bone marrow cells are right here. And these big fat white cells, these are fat, this is fat. And so what happens in the telomere biology disorders is that you lose those bone marrow cells, the cells that give rise to blood. And over time, the bone marrow is replaced by fat cells over on the right. And this is when we say that the bone marrow is hypocellular. It's for patients given age, and as we get older, and there's some older people in the room like me, right? My bone marrow it's not as cellular as it was when I was like 10. But over time, it's normal aging. This happens really rapidly. It happens much earlier in the TBDs. Okay, so you get this hypocellular marrow, not enough cells for patients given age. And so this is just some data that came from the NCI and the Shepherd's group and Sharon Savage and others, showing that bone marrow failure is actually fairly common. Some estimates up to 80% in the TBDs. It really varies depending on how you describe or define bone marrow failure overall, but the point is, it's common, okay? So, what are the consequences? Well, the consequences are, you're not making enough blood cells. So if you don't make enough red blood cells, that's when you're anemic, and your symptoms, you may look very pale. Actually, sometimes family members don't notice this, right? It's maybe a relative who hasn't been to the house for a few months and comes and says, oh my God, Janie's really pale, right? So, because it happens slowly over time, it doesn't happen acutely. But you can see fatigue, just inability to walk across that parking lot to get to the mall, right? People get tired more easily, difficulty walking up the stairs when you're severely anemic. So anemia, you can have low platelets, that's the thrombocytopenia, and you may be bruised more easily, don't know where that bruise came from, that big, bruise that you can actually feel, a palpable bruise. The petechiae, those little red spots, and then just bleeding. When brushing the teeth, bleeding, in the stool, blood in the urine, places like that. And then there could be total white blood cell counts can be low, or just those neutrophils, which are bacterial fighting cells. And so this puts people at risk of infection. So these are the kinds of consequences that we see with bone marrow failure. Now, when we talk about the degree of bone marrow failure, this came up yesterday in a conversation I had in the hall. It's not about the cellularity. we base it based on the blood counts, okay? And so we will refer to bone marrow failure as being mild or moderate or severe based on where the blood counts are. And it's not just a moment in time, it's, you have to have a couple blood counts to get a sense of it, right? So the neutrophil count, if it's less than normal and maybe up to 1,000, so between like 1,000 and 1,800 depending on your age, that would be mild. But once it starts to drop below 1,000, then we can start talking about moderate or severe. And same with platelet count, so the degree of thrombocytopenia is going to dictate whether it's mild, moderate, or severe. And then hemoglobin, we don't have as much gradation, it's either above 8 or it's below 8, right? But the point is that it's not the cellularity, it's the blood counts that matter. And sometimes people can have really just completely normal blood counts, but when you look in the bone marrow, you're starting to see that hypocellularity. So just because the blood counts are normal doesn't mean that the bone marrow is not hypocellular. But again, at the end of the day, it's about, is the bone marrow producing enough blood cells? Okay? Now, when we think about symptoms, really patients or individuals become symptomatic when they're in that moderate to severe range. Okay? So, how do we begin to screen for bone marrow failure? In many individuals, they will first come to a hematologist. That's how they're first diagnosed with a telomere disorder because they have something wrong with their blood cells. But, what are the things that we're looking for? Well, first and foremost are signs and symptoms, right? So, we can talk about CBCs and bone marrows, which I will in a moment. But really what's important at any given point in time are there symptoms. So are there symptoms of anemia, which we went through, or thrombocytopenia or leukemia or neutropenia? So symptoms are very important. So maybe, you or your family member has a CBC done 6 months earlier, and you're told you don't need to do one for another 6 months, but maybe in 3 months you start to notice something, some bruising that was never happening before. You don't have to wait for 6 months to get that CBC. So signs and symptoms are very important. Now, CBCs, how often we do them depends. And one point I want to make here is that we have guidelines. These are guidelines. They're not rules, they're guidelines. And so sometimes for a given patient, one set of how often we do CBCs makes perfect sense. And for another patient, for maybe some other reasons, a different set of frequency makes sense for them, okay? And reasonable doctors can disagree a little bit about how often things should be done, right? So, again, these are guidelines. So if someone's got stone cold normal counts, who might this be? This might be a patient, for example, who has been diagnosed as carrying a mutation because a family member has a mutation. And so they know that they have one, but the blood counts are normal, right? It could be somebody who presents with some other medical problem associated with the telomere disorders. Maybe they have pulmonary fibrosis, maybe they have, the mucocutaneous triad, right? The blood counts are normal. So sometimes we do see patients like that, and they don't necessarily have to have blood counts every month, right? Every 6 months. Some patients even once a year. If everything's really normal, patient's doing well, and there's not concern at the present. But again, signs and symptoms are important, so if things change, then you would want to do them again, or sooner. Maybe someone's got some mildly low, they're in that mild bone marrow failure category, but their counts are really stable. They're not changing much. Every 3 to 4 months, maybe every 6 months. But the point is, you're going to do them a little bit more often. What if you have patients whose counts are dropping? They're going down. Each time we see the patient in the clinic, their counts are going down. Those we want to follow a little bit more frequently, right? Because we want to make sure they're not getting into that range where we might need to do something about it, right? And so we'll adjust how frequently we do these based on what's going on with the patient. Now, sometimes you can start seeing counts going up, which would be a little bit odd. And that also, maybe you might want to look at that a little bit. Like maybe the hemoglobin's going down, the platelets going up. You might want to kind of follow up on some of these things a little bit. And we'll talk about the other way to assess this is bone marrow aspiration and biopsy. So I talked about the blood counts are what matter, then why do we do a bone marrow if the blood counts are what matter? Well, because we want to make sure that there aren't early signs of what we refer to as myelodysplasia. The cells are starting to look funky, F-U-N-K-Y, under the microscope. Or myelodysplastic syndrome can be diagnosed in an individual, or maybe they're developing leukemia. We want to look to see if there's any chromosomal or cytogenetic or genetic down to the DNA level changes in the bone marrow itself. So these are the reasons why we'll do a bone marrow. It's not just to assess the cellularity. I mean, maybe it's a patient we've never seen before. They have low blood counts. We do a bone marrow because we do want to know, is it hypocellular? But once we kind of know that, that's not what we're really looking for. We're really looking for these other things, at least I am. So what do we recommend? That the patient should have an aspiration and a biopsy, to do studies that let us look at the chromosomes, cytogenetic studies, special things called FISH studies. It has nothing to do with FISH, it's an abbreviation, to look for the most common changes that are seen in MDS or myelodysplastic syndrome. Some institutions will do what we call flow cytometry to look for those blast cells that are associated with leukemia or signs of leukemia every time they do a bone marrow. Some institutions, like my own, our pathologist feels that they can look under the microscope, and if they aren't seeing increased numbers of these blasts, they don't run the flow cytometry every single time, right? So it varies from institution to institution, and really outstanding pathologists can disagree whether or not it needs to be done or not. And what I would say, there's emerging use of what we refer to as next generation sequencing, or NGS, panels, to look for changes in the DNA, and I'll explain to you a little bit more about that in a moment. So how often might we do bone marrows, right? So if the counts are really normal, many would propose getting a bone marrow at diagnosis, and I think that's probably a most common approach. Personally, I have had patients with completely normal blood counts, and I know their genetic cause of their short telomeres, and I personally weigh the risk of getting general anesthesia for a procedure that I don't think is going to change how I approach that patient. But there are differing opinions on this, so I just want to let you know that it's probably more common for people to say, let me take a look at the bone marrow, so we get a baseline. And that's reasonable as well, just kind of know what it looks like. Okay? Now, if the counts are continuing to be really, really normal, some would say, again, you don't need to repeat the bone marrow, but some would say, I still want to see it, and I'll check it every few years. Or if the counts start to drop. Now that's when, you might want to look to see what the bone marrow looks like at that point in time, if the counts are now becoming abnormal. Now, if they are abnormal, but they're mildly so, and they're very stable, again, how often do we need to do this? There's no strong science to tell us how often to do these tests, okay? There's no data yet. Maybe someday there will be. But right now, what we'll say is, okay, maybe once every year. I think it's common. Some people might push it out to every 3 years if they're mild cytopenias, mildly low blood counts, but they're very, very stable, okay? And then, what if the counts are falling? Well, that changes game. If we see something called the MCV, and I'm sorry I didn't write this down, but that's the mean corpuscular volume. That's the average size of the red blood cells. And if that's starting to climb, that could be a sign that something's changing the bone marrow that we would want to know. So there are times that we might do a bone marrow every 6 months, every 3 months. We may do a bone marrow 2 months later, okay? So again, there's no hard, fast rule, but it's... the point here is that sometimes they do need to be done. Okay, so now, when we do the bone marrow, what are some of the findings that may be concerning? Well, obviously, if there's leukemia, that's hugely concerning. If there's what I mean by frank MDS, I mean like any pathologist looks at it, says this is myelodysplastic syndrome. The cells that give rise to platelets, the cells that give rise to red blood cells, the cells that give rise to those neutrophils, they all look really abnormal, and there's lots of them. That would be like a no-brainer, right? So there could be very frank MDS. There can be subtle changes in the way the cells look, And really, an expert pathologist knowing the TBDs would be able to say, that's not uncommon. That, that's not anything urgent that we need to deal with. But if there's frank MDS, or there's certain kinds of chromosomal changes, if that's all you see is a little bit of a cytogenetic change or chromosomal change, and the marrow otherwise looks not NOT dysplastic, one, depending on what the chromosomal change is, one might pause and not feel like there's an urgency, but sometimes there can be. For example, if there's complex changes where there's multiple chromosomal abnormalities, that might really drive somebody to say, this does not bode well, so we need to act, okay? Now, so if there are concerning cytogenetic changes, again, you're going to do your CBCs more frequently, you're going to do your bone marrows more frequently, and again, the frequency is going to depend on what the change is, and if things are super stable, or maybe things are looking a little bit better, which sometimes you can see, those can be spaced out over time, but you're going to want to monitor fairly often initially. And then there's, again, certain changes that might warrant, just moving more rapidly to getting treatment. Now, these NGS panels, and I mentioned this a minute ago, these are assessing for acquired. These are changes in the DNA that are not present at birth, they're not present in all the cells. These are acquired changes. And these DNA sequence changes can be detected from a bone marrow sample, or some people will look at blood. And it's not looking at every piece of DNA, every DNA sequence in the body. Most of these panels are really, or almost all these panels, are targeting genes that we know that are associated with the development of leukemia. So these are very specific panels. So at my institution, we have a panel of about 175 genes. There are panels that are available that have fewer genes. There are some panels that have more genes. So they vary. There are also some genes, TERT. Probably everybody in the room is familiar with TERT. Well, the TERT promoter, that's the region of the gene that helps, that's important for expressing that TERT gene, to make that TERT protein. Well, in certain types of cancers, that promoter gets mutated. This is a very, very common kind of mutation in many different kinds of cancers. And that causes more TERT to be expressed, more TERT protein. So that can happen. Well, we've learned that there are people with telomere biology disorders that can acquire a TERT promoter mutation to compensate for that low level of TERT protein, or that abnormal amount of TERT protein, or the abnormal TERT protein itself. So we refer to these as adaptive changes. So some of these panels may have a few of those genes where we can see those adaptive changes, okay? Now, I would at best say this is an evolving field of study. We don't have solid answers to know, first of all, what's the best approach, what are all the genes that we should be looking at. We don't yet know how to interpret certain findings, like what's the significance of certain findings, and how to respond to those. And Dr. Farrar here is a researcher who's studying these kinds of questions. And so, I think, we hope in the future we'll have really strong guidance to tell us, again, what kind of panel to do, how do we interpret certain findings, and how do we respond to those findings. We're not there yet, but what I would say is at many, many, many institutions, we will still incorporate these, because there are certain things that if we see our sort of expert opinion would be, that concerns me, and we might want to do something about that, okay? So, how do we continue on once we detect what we would refer to as these genetic changes that are concerning? It's very similar to those cytogenetic changes, I think, in general. Okay, so when do we treat bone marrow failure? Well, we'll treat it if you've run into that more severe range. Am I running out of time? Oh, okay. I'm sorry. I'm kind of going slowly, but I saw that I started 10 minutes early, so. Okay. If the blood counts are just getting into that low range where patients are going to have symptoms, so this is when we have that aplastic anemia, that bone marrow failure that's gone into that severe range, hemoglobin's less than 8, or the platelets are less than 30,000, the ANC is below 1,000, certainly if it's below 500. These are values that would prompt someone to say, maybe it's time to get some treatment here. Myelodysplastic syndrome, in most cases, would really lead someone to go ahead and recommend treatment. If there's frank leukemia, yes, there's treatment. And I believe Dr. Savage is going to talk about cancer, including hematologic malignancies, during her session. So how do we treat bone marrow failure? Well, there's different ways. Transfusion support, growth factors that stimulate the bone marrow, androgen therapy, stem cells, transplantation, and Dr. Agarwal is going to talk about that tomorrow. And gene therapy or gene editing, and Dr. Myers is going to discuss a trial that's currently ongoing as well. And I think your talk is tomorrow, right, Cass? Okay. So I'm not going to touch on these last two topics because you're going to get the experts to talk about those. But let's talk a little bit about transfusion, when to transfuse or not to transfuse. So, transfusion of red blood cells, so lucky that we can do that, can help alleviate symptoms that are associated with anemia. If you've got a small child, you might want to transfuse at levels that maybe for an adult you wouldn't necessarily transfuse because you really want to support optimal growth and development of the child, right? So these values, these thresholds vary from institution to institution based on the patient's age. If you've got a highly active individual as opposed to a couch potato by nature, right? Again, the transfusion thresholds might be a little bit different. However, we've got to recognize there are risks of transfusing red cells, and those are iron overload. The body doesn't have good ways of getting rid of iron, right? And alloimmunization, where the body starts producing antibodies that will complicate that transfusion. It won't let you the body doesn't hold on to those red cells so much anymore. With platelet symptoms, it's important if you've got a patient who's bleeding, I don't really care if the platelet count is 30,000. If they're bleeding, they need platelets, right? But some patients will have quite low platelet counts, less than 10,000. And they're not bleeding, but that might be a time to say, we're going to give you a platelet transfusion because we want to reduce the risk of spontaneous bleeding. I have patients that travel many hours in a car to come see me, and it always causes me great angst when they arrive at my clinic and their platelet count is 5 and they've been on the highway, it just drives me nuts, I'll be honest with you, okay? And then along with risk, you've got a toddler who you just can't tell them to stop running around. So there are different thresholds. But again, if you have someone who's very cautious and they're sitting around, they can tolerate platelet counts of 15,000 and they're doing fine. It's not a big deal. I mean, it's not good, but in other words, they're not at tremendous risk. And then granulocytes, those are those neutrophils, right? So, we don't routinely transfuse those, but if a patient has an uncontrolled infection and they're severely neutropenic and you've got to treat that infection to be able to move on to the next kind of therapy, many institutions will provide granulocytes, but it's not something that you just pull off the shelf. It requires teamwork, including the family, friends, so forth, to get that on board. So I won't go through all the details, and hopefully no one in this room will need them or their family member will need them, but it is something that takes a significant amount of legwork to happen, and it has a different set of risks, but hopefully those won't be needed. Okay, so androgens are a therapy that are used, and I will say the implementation of androgen therapy, again, is going to vary from institution to institution. There may be an individual whose blood counts are quite low, they're meeting that need treatment stage, and they have a sibling who's healthy, isn't affected, a full match, and the decision may be to proceed to transplant. There may be other circumstances where maybe the individual isn't in a condition to proceed to transplant. Maybe there aren't good donor options. Maybe the family is just terrified about transplant and they don't want to do that first. So androgen therapy is an option, but it's not a 100% effective option either, right? So androgens are those quote-unquote male hormones. Just so you know, females do also make some androgen, right? So it's not, not changing a girl into a boy. They are a type of steroid hormone, but they're different than prednisone. Many of you know about prednisone. They're in a class of the so-called anabolic steroids, but no one comes in, hulking, kind of bulky, on their Danazol. And two of the more common ones are oxymethylone, which isn't used so much. I don't even know if it's available here in the US so much. I know people have had difficulty getting it. And then Danazol is the one that's used most often now in the US, is my understanding. And it's what we would prescribe. So I'm just going to go in through a little bit of the details, because Danazol might be something a doctor has talked to you about, and some families are still weighing, is that what I would do if I get to that point? So I want to go through a little bit of data. It's a little bit old. It's the same data I showed last time, because we really don't have new data so much on this, but there was some suggestion that Danazol could work through initial retrospective study that was done by Dr. Savage's group, where they looked at several individuals with telomere biology disorders due to a variety of different genes. They were treated with different types of androgens, and what they found was that about 70% of the patients, their hemoglobins got better, a fewer number had improvements in their neutrophils and their platelets, but there were some adverse effects. So the lipid panels got a little out of whack, not in a positive way, but in the kind of things that we don't like to see, like higher LDLs, lower HDLs. And there were two cases of this, what we refer to as splenic peliosis, where there are these referred to blood lakes, where there's this dilatation of these vessels within the spleen, and it also can happen within the liver, and there was some rupture in two cases. So that's certainly a worrisome finding. Now, there was a prospective trial. So retrospective, these were patients that weren't treated on a particular study, but data were collected on those individuals and analyzed. Prospective study is when patients are enrolled and you collect data in a very uniform and systematic way over time. And you learn things from retrospective studies, but you learn different things from prospective studies. And prospective studies is also, often the gold standard. And randomized double-blind studies are even more gold standard. But this study here is they just had some individuals where they treated them with Danazol, and these are individuals with telomere biology disorders. And what they were asking wasn't, does the blood counts get better? Although they did look at that, they just want to know, is the rate of telomere shortening, did it get less than what would be expected? They didn't have a control group. And they did look again at the blood counts, but that wasn't the primary endpoint. And they had they had 27 patients specifically, a variety of genes impacted. Over half had moderate aplastic anemia, 2 had MDS. And there were several that had the subclinical pulmonary fibrosis, and 9 had cirrhosis. So multiple organs affected in many of these. And what they found is, and this is shown here, is this was where the telomeres, they were actually not declining the extent that they thought. In fact, telomeres got a little bit longer, and they expected them to be changing in a different way. So that is to say, shortening. And this is another graph. So this is looking at all the individuals. They saw that the telomeres were average, the lengths were increasing, and then when they came off Danazol, they went back down. So this was very exciting to them, and they thought, oh my gosh, we got it. Danazol causes telomeres to get longer. They also looked at responses to blood count responses. And in green, that's better. Blood counts got better. Gray, the patient had come off study. Maybe they didn't tolerate the Danazol, or they had some other significant complications that had come off Danazol. And the orange, they didn't respond. So you can see there's a lot of green, there's a fair amount of gray, there's some orange. So it wasn't a home run in every single patient, although the blood count or the telomere lengths were improving. Now, again, Dr. Savage's group, we contributed some to this as well. We went back and looked at some patients in which we looked at their telomere lengths when they were on androgen therapy. And this time we used what we call telomere flowfish, which many of you should be familiar with, whereas in the other study used an approach called PCR. And so we looked at those who were not treated with androgen and those who were, and fewer patients, again, spectrum of genes, both patients that were treated with androgens and then those who were not. And what this shows here, if you look in red, those who were treated with androgen. Those in blue were not treated with androgen. And you can see the lines represent one measurement and then a subsequent measurement. And you can see they're going all different directions, whether or not they were treated with androgen or not. So our conclusion, using statistical analysis as well, is that it really isn't a consistent finding secondary to Danazol or any kind of androgen. And shown here is looking at different mutations. So it wasn't specific, there wasn't a specific effect related to any specific mutation. Okay, so That all being said, the data is clear that some patients can have improvement in blood counts, and if you have a patient who maybe transplant is not indicated at that time, or a patient where transplant is not possible or is not desired, Danazol is something that can be trialed in patients, and we do that in my clinic. But there are some side effects that people need to be aware of. There can be virilization or masculinization of females. Danazol has fewer of this. This has less potential for this side effect than other androgens, and that's why it's it's preferred. There could be, patients might start growing more than they were before, but that's not necessarily good. Maybe sort of this premature puberty, so their growth plates may close prematurely and then they stop growing sooner than they should. Lipid changes, liver toxicity can occur. There can be some behavioral changes. And in addition to this peliosis that I described, liver adenomas have been described as well. These are rare, but they can happen. So, patients on Danazol need to be followed with respect to their liver. They should have ultrasounds of their liver and spleen, checking lipid panels, doing GU exams for precocious puberty, and monitoring their height. Now, what we don't know about Danazol is, what is the effect on telomere length and blood cells, and how is that achieved? How does it work? If it really does, and again, I'll show you a study in a moment. So our data was retrospective, patients on different types of androgen. We can't be 100% sure. There's a prospective study going on now that will quantify telomere length changes based on flowfish and have good data on patients before and after starting Danazol. But if it does increase telomere length, how is that achieved? What is the mechanism of action of improving blood counts? Maybe it has nothing to do with telomeres. We don't know. What are the long-term effects of its use in patients? For example, does it lessen or increase the risk of MDS or AML? We don't know. Does it alter the course of other TBD clinical features like pulmonary fibrosis or cirrhosis? So there is a study ongoing recruiting patients at the NIH. I strongly recommend if there's a discussion with a patient about potentially starting Danazol, that I would consider participating in a clinical trial. So that's how we're going to answer these questions. We're not going to answer them by, patients being treated in clinic here and there in different ways. Prospective study is the best. Growth factors can be used as well. So we can stimulate red cell production using something called epoetin, and this is the hormone that drives red cell production. We can stimulate neutrophils with something called Neupogen or filgrastim. This can be done. However, this does not always work. Neither of these, in both cases, you don't always get results, but sometimes you can. It might be useful to do that if there's a patient who's transfusion dependent and their erythropoietin levels are low. One might consider giving some more erythropoietin. Or if there's a patient who's persistently neutropenic and maybe there's infection and you just want to see if you can get those neutrophils up, then treating with G-CSF would be appropriate. But we still don't know, is there an increased risk of myelodysplasia? In other bone marrow failure disorders, it's been discounted, this idea that G-CSF will drive MDS or AML. The telomere biology disorders, not enough patients have been treated, or not that many patients have been treated in this way, so we really don't know. So I think it's still a question. With erythropoietin, sometimes there's concern about increasing risk of thrombosis in certain populations. For example, individuals who are on dialysis are often treated with erythropoietin, and there's a lot of concern about thrombotic events that lead to stroke or death. So we just have to bear that in mind. Okay, and we talked a little bit about the splenic or hepatic peliosis in the use of androgens, and we know those that appear to be at greatest risk of that problem are those that are on these growth factors at the same time. So we don't treat patients who are on androgen with growth factors because we're concerned it's going to increase this risk of this from happening. Did my timer stop? 8 minutes. Oh, okay. Now, in questions, okay. Dr. Savage, how much detail are you going into on MDS and AML?
Not a lot.
Okay, so I'm going to talk through these last few bits very quickly. So, normal bone marrow, very cellular, aplastic anemia, or this marrow failure that we see in patients far fewer of those cells. In myelodysplasia, you start to see the cells looking very abnormal in their appearance. And as a consequence, and the marrow can become more cellular. So sometimes increasing cellularity is actually not a good thing. Sometimes that's associated with evolving MDS or ultimately leukemia, right? So a more cellular marrow when it's been extremely hypocellular should be a red flag, first and foremost, to the pathologist and the treating hematologist to consider, is this because there's evolving MDS, right? But you can have a cellular marrow with MDS, for example, and in most patients with the TBDs, this could be more of a hypocellular MDS. But the point here is that those cells are not producing blood cells normally. Even though the numbers aren't so bad, they're not producing blood cells normally. So, and these cells, they may enter the bloodstream, but they don't last as long. They can accumulate in the bone marrow. Again, the cellularity can increase and it can progress to leukemia. We do know that there's an increased risk of MDS as well as AML in patients with the TBDs and dyskeratosis congenita, as described here by the NCI cohort. So it's been found in others as well. Okay, so I'm sorry, I missed it. Okay, so when do we treat? Well, MDS, when we see multi-lineage, that is the cells that give rise to the platelets and the red cells and the neutrophils, we see multiple lines that are looking quite abnormal. It's progressing. In terms of the dysplasia, we might be starting to see more of those blast cells. They're increasing. It doesn't meet the criteria for leukemia, but it's starting to get concerning. And again, if there's certain chromosomal associations, abnormalities that are associated with this would be, again, very, very concerning. So how do we treat stem cell transplant? So Dr. Agarwal will talk about that. There are drugs that are used often in cases of what we call low-grade MDS in adults, not associated with TBDs. We really don't know if these are effective in the TBDs. And I'm just going to cut to my last slide, and that is to say thank you for being here. These hematologic manifestations will vary. They can be very minor, and they can be quite profound. The treatments of today, I always say, are not going to be the same as treatments of tomorrow. And I think the advances that have been made, for example, in stem cell transplantation, I think is, that's the example, right? So, how things are managed today may vary. And so just bear that in mind as you think about situations where the marrow failure may not be very severe right now. 5-10 years down the road, doctors may be talking with you about something really quite different. Treatment on clinical trials is always preferable in these rare disorders where we don't have solid data yet, and always ask questions. Okay, so I'll stop there. Any questions?